Hello and welcome. I'm Adele Gauthier from Breast Cancer Foundation, and tonight we're talking about breast reconstruction. Before we get started, some housekeeping. I encourage you to make the most of the chat box. At the bottom of your screen, you'll see a taskbar or a status bar. If you can't see it, you might have to move your cursor down to make it appear. On that bar, you'll see a chat icon. Click on that to open the chat box, and if you have any technical issues, you can type details of the problem there and our support team will get in touch. You can also use the chat box during the webinar to ask questions, which we'll get to later, and you can also chat to other people there. Don't worry about missing out on information while you're chatting. The webinar is being recorded and will be available on our website tomorrow. If you're having trouble with sound, you could choose to dial in by your phone and watch on your computer. You'll see the phone number on the screen there for you. Right now, you should be able to see us panelists in a small box on your screen. If you want to make that box bigger, just drag the corner of it. Okay, so tonight we're talking about breast reconstruction. Whether you're having a lumpectomy or a mastectomy, what are your options and what does your surgeon actually do for you? Well, we're going to hear tonight, first of all, from Vivian and Erica, two people who've had breast reconstruction. And then we have surgeons Mr. Michael Puttick and Ms. Meredith Simcock, who will talk about how doctors aim to both treat your cancer effectively and give you a good outcome from an appearance perspective. Vivian and Erica are twins, and they've both had breast reconstruction in very different circumstances. So, Vivian, tell us your story, how you ended up having breast reconstruction.
Well, I was diagnosed back in 2015 when I was 29 with a grade 3 triple negative breast cancer. Because of my age and the type of cancer, this caused some red flags, which meant I was then referred on to the genetic services, where I was screened for mutations in the BRCA1, the BRCA2 and the P53 genes. They ended up finding a mutation in the BRCA1 gene, so it was decided that due to my age and the high risk of another cancer forming in my life, it would be best to skip radiation and go straight to a double mastectomy and reconstruction. Because I had returned a positive result for the BRCA1 mutation, it meant that the genetic services was then able to open up the screening for the rest of my family, which included my twin sister Erica.
Right, and so Erica, what happened when you had that?
Yeah, so basically when we got the call that Viv had it, then I had a 50-50 chance. So I was able to piggyback off her genetic counsellor in Auckland, which was fabulous, so they could get me in pretty quick. I think from memory it took it 2 or 3 weeks to get me in. So then I got tested, which was just a simple blood test, and about 6 weeks later mine came back positive, which meant that, that I was then offered the opportunity of doing a preventative double mastectomy with reconstruction.
Right. So what were your options and what did you end up choosing and why, Vivian?
Well, due to my size and my build, I was unable to have any reconstruction that involved using my own tissue. So I ended up choosing tissue expanders placed under the pectoral muscle, followed by, and ended up choosing to have implants placed down the track. The main reason I chose this was because it was more freedom to be able to choose than having direct implants, as with the direct implants it sort of comes down to the day as to what the surgeon feels looks good on you, but that may not necessarily be what's right for you. So
size-wise?
Yeah, size-wise. Yeah. So I ended up wanting the expanders because it meant I could literally fill it up to the point that I felt comfortable and then have the implant of the same size put in order to be the right size for me. I also did opt with going for the nipple sparing surgery, as the idea of having no nipples made me feel a little uncomfortable because it would be a constant reminder to both my husband and myself of the cancer diagnosis, which was already traumatic enough.
Yeah, I bet. So Erica, what about you?
Yeah, so I decided to choose nipple sparing as well, but I was going under the muscle with a saline expander implant. So just like Viv, I was quite a slight frame, so I didn't have a lot of fat to use. So we decided pretty quick expander was the way to go. I liked the idea of expander as well with the size control. So, but my type of expander, the idea was that if successful, it could turn into a permanent implant. And so I like that idea of having a kind of more of a one-stop surgery with a small procedure as opposed to a full exchange surgery. The reason for that was really around financial. I needed to get back to work quickly. I also had a daughter who was 7 at the time, so I needed to, kind of get back into daily life as quick as I could, and that was kind of one of the quicker recovery types of surgeries. I went for under the muscle because I wanted to have it protected as possible. I was worried about rupture. My job can be quite physical at times, and so I wanted to make sure it was kind of covered as much as possible. And then also I wanted nipple sparing for a couple of reasons. One, I wanted to look down and know that there was a little bit of me still down there after a mastectomy. Kind of everything gets cut away, so I did like the idea of still seeing a bit of me. And then also I was 30 and I was about to enter back into the dating market, so that was kind of an aspect to keep those for kind of self-confidence and positive body image and things like that. So it did take me about 8 months to get in to do my surgery, just because I was going to be off for 4 weeks minimum, and that's a long time to be away from work, so I just had to kind of wait until there was a quiet period. So yeah.
So they sound like great plans. How did it actually go?
Well, unfortunately for me, my reconstruction didn't go according to plan. My plastic surgeon prior to the operation had ended up ordering the wrong size tissue expanders, which meant when he went to place them into the new breast pocket, they didn't fit. He then ended up taking a spare pair of implants from another patient, which also didn't fit very well. The main issue was that the surgery was performed for tissue expanders and not direct implants, so the pectoral muscle was not cut. This meant that the breast pocket, which was supposed to be gently stretched over a period of months, ended up being stretched in a matter of minutes. So I ended up with nerve damage and a lot of pain, which resulted in shooting pains up and down my arms, as well as pretty badly disfigured breasts.
Wow, okay. Erica, have you got a different story?
I do, thank goodness. So my initial surgery was really successful. So it was a big surgery. I was under for about 6 hours. But the care that I got from Waikato Hospital with the pain management and post-surgery support was fantastic. It was a big recovery. It was 4 weeks. The first 2 weeks I couldn't lift my arms up. I couldn't do any downward pressure. I had 7-day-a-week rostered help just to kind of do life. After that, the next couple of weeks was pretty good. You started to get your strength back and mobility and things like that, which was great. And so then at the 4-week mark, I was ready to go back to work. But the only major glitch was when they were doing the mastectomy surgery, they accidentally, when they were cauterizing me, accidentally burnt me, which was just kind of a freak accident. But it turned out just to be a very small blister in the inside of my right breast, which is nothing. They just popped a plaster on it. We thought that was that, but it ended up getting infected. And so because of that, then they had to take me back into surgery to cut the infection out, because they were concerned that if it kept going and got to my implant, then we would have to take the implant out and I would have to go flat until we could reconstruct it. So that was a bit of a glitch. But then we thought it was okay, and then within that next year, unfortunately, my right breast got capsular contracture, so we had to take the saline expander implant out and put in a permanent silicone implant at that point. We left the left because lefty was looking really good. I called it lefty. Lefty was looking great, so we didn't want to mess with that. But then in the following year, my left started getting quite bad rippling. So my surgeon, wasn't too happy with the look, so we exchanged that and put a silicone in my left to match my right. And then that concluded my 4 surgeries.
Okay. So quite a bit going on there as well, although a bit more positive. Where are you at now, Vivian?
Oh, well, my breast specialist was absolutely amazing, and she always worked hard to make sure that I was happy with my new breasts. It became a personal mission. Because of the end result, I ended up having to have another reconstruction done with another plastic surgeon, which she referred me on to. He ended up having to remove the implants, reattach my pectoral muscle back to the original place, and start the reconstruction from scratch. My new surgeon decided to actually go over the pectoral muscle this time, and he was able to use direct implants because obviously at this point in my life it was a bit daunting having another surgery to look forward to, essentially, because I had my son to care for. The surgery was really well done and went perfectly, and the recovery period was extremely quick. I'm very happy with the result, as I now have beautiful looking breasts which are very close and feel very normal to my original breasts.
That's great. And Erica, where are you at?
Yeah, so I'm really great as well. So I love my new boobs, they're fantastic. The nipple sparing was hugely successful. So straight after the mastectomy, they both went black. So there was a little bit of period in there where we thought we might lose one, but we didn't, thank goodness. They pulled through, which was great and look as good as ever. They're not perfect. There's the odd little indent in each breast, and with the implant sitting underneath the pectoral muscle, when I tense the muscle, it does tend to distort a little bit. But at the end of the day, natural breasts aren't perfect either, so I'm not really too worried about that. They are firm. They're firm to touch. I kind of describe it as walking around with a padded bra on at all times, but you're not wearing one. But in saying that, it makes them really perky. And that's not such a bad thing. So I don't have to wear an underwire bra at all, which is a huge bonus. But no, I love them. They're great.
Great. So just to wrap up, looking back, knowing what you know now, if you were doing this all over again, what would you have done differently?
Well, I probably would have asked more questions and been more assertive with my plastic surgeon, as often my husband and I felt we were being rushed through and a little intimidated that our concerns were being shut down and swept under the rug like we were being silly. So we ended up being quiet and just trusted that the surgeon would do a good job, as he had most likely done thousands of this type of operation before, which essentially was the biggest learning curve for us, because we now realise how important it is to not be afraid to speak up if you feel things aren't being handled properly, because it is our bodies after all. So it is our right to make sure that we're being taken care of and most importantly listened to.
Right. Yeah.
Yeah. So for me, probably I'll look seeing how good Viv's results are with over the muscle. I'll probably do a little more research into that. I kind of assumed the risk of rupture, but didn't really get the stats behind it. So maybe I'd look at that a little more. But in saying that, I do love the perkiness. So I don't know if I would give that up. So maybe I would do everything the same again. I'm not sure. I don't know.
Okay, and we'll talk a bit more about those options later with our surgeons here. Thank you so much, both of you. That was super helpful and informative for everyone at home. And you guys out there, don't forget to use the chat box, cursor down to that, to ask your questions or to chat with each other. And in the meanwhile, we'll crack on with Mr. Michael Puttick. He's an oncoplastic breast surgeon at Auckland City Hospital and at Breast Associates. Is there something wrong? Oh, yeah, okay, sorry. Mike, oncoplastic breast surgery is a newish term for most of us. What does that mean?
Really a combination of, so the onco part of the word refers to cancer. So surgical oncology is surgery for cancer, and people who perhaps need chemotherapy or some other drugs, a medical oncologist. So that's where the onco part comes in. Plastic really is around reconstruction and aesthetics, and it's really a term that I hope will almost not be necessary for most breast surgeons, that every breast surgeon will become oncoplastic, because they're not just considering the cancer outcome, but actually the look of how the breast looks at the end of it. So really a sort of combined term. Shall I go on?
Yes.
Great.
Yes. I think that, yes.
So just to give an overview of breast cancer treatment, it's changed a lot over the last 100 years, thankfully. 100 years ago, very radical surgery was proposed and everybody had a mastectomy, but on top of that, a lot of tissue around it and muscles and lymph nodes were taken on absolutely everybody. And the philosophy then was really trying to do the most aggressive surgery that the body could withstand. And over the last 100 years, we've really found that you can get equivalent results or just as good results with much, much less surgery. So now we've worked very much more towards doing the minimum effective treatment that people need, which I think is better for everybody. One big change that came about 30, 40 years ago was the trials showing that not everybody needed a mastectomy, because up to that point, if you had breast cancer, however big or however small, everybody was recommended to have a mastectomy. And we now know that if you do what's called a partial mastectomy or a wide excision of the cancer, provided it's backed up with radiotherapy, the results are just as good. What you're trying to do with a breast cancer operation is remove the abnormal area and have a rim of normal tissue around it. And that's why you get the term wide excision or partial mastectomy. And whether you have that can depend on the patient's preference, what you want, and partly the size of a tumour relative to the size of the breast, and sometimes the position of a lump or a cancer within the breast. And it's amazing that even without removing any skin, you can take out quite a reasonable chunk of up to maybe 1/6 of a breast tissue, and in most people maintain symmetry. A few provisos around that of where in the breast it is, but you can do quite a successful operation and people are still looking symmetrical. So oncoplastic surgery, as much of anything, it's an approach, it's a combination of techniques. It's breast surgeons who historically have been what we called general surgeons, learning from our colleagues in plastic surgery, and really having a consideration not just for the cancer outcomes, but for the cosmetic outcomes. And the techniques can be techniques around doing a partial mastectomy and actually reconstructing the breast to be breast-shaped at the end, rather than perhaps having 3/4 of a breast with a dent in it, but also encompasses reconstruction options post a mastectomy. And the idea is that it's considering aesthetic issues, quality of life issues, as well as cancer outcome issues. So what we're trying to achieve really is a number of things, which is a good cancer operation, because that is obviously a priority, but a good cosmetic outcome and symmetry. And it isn't always replacing what somebody has started with a like for like necessarily, but the aim that you can give people good breast-shaped breasts and symmetry that are comfortable. And we've already heard from our other panelists tonight, the idea of just feeling self-confident that it's part of yourself, and it's a combination of thinking about where scars go, moving some of the breast tissue around from where you've taken a lump out, some techniques about actually replacing some of the volume, and if for puncture mastectomies or the lumpectomies, just going to talk a little bit about the idea of a therapeutic mammoplasty. But actually for many people, and if you've had a screen detected cancer, just a simple lumpectomy is all that is needed. So a therapeutic mammoplasty, only suitable for a few patients, but sometimes people do come in, and what comes out in the consultation is that they find their breasts are much larger than they were. They've always wanted a reduction. And a breast reduction essentially is removal of some breast tissue and removal of some breast skin. And if you design your incisions so that a breast cancer is included in that resection, you can actually do a breast reduction along with it. And for some people, that's a silver lining at quite a difficult time of life. But as I said, it's suitable for a few patients, but not everybody. Some people, that said, for various reasons, will be either choosing to or recommended to have a mastectomy. And very often it's due to perhaps the location or size of the lump. And perhaps if there's more than one cancer within a breast, we'll be recommending a mastectomy. And my starting point for them is that everybody should be at least considered for having a reconstruction with it. And that may not be suitable for everybody. And in fact, the majority of women in New Zealand who have a mastectomy do not have reconstruction. It does complicate the surgery, the risks go up. So if you have a lot of comorbidities, and sometimes that can be age-related as well, then it may not be suitable. But it's a combination of the surgeon's recommendations around successfully treating the cancer, and also what the patient wishes and what their expectations are. And the other thing that can play into decision making is need for post-surgical treatments such as radiotherapy and around the timing. In simple terms, a reconstruction can be either immediate, that's at the time of your cancer operation, or a delayed one, which could be sometime later at a time of choice, or at a time when all the other adjuvant treatments have been done. And there may be some patient reasons that they choose, and there may be surgeon recommendations or the specialist recommendations saying, don't have a reconstruction now. Certainly some people will come along to a consultation and they would say, look, now all I want to face is what I need to do. And perhaps some of these things where they've got more choice over are optional, they can come and visit at a later stage. If somebody needs radiotherapy, we're much more likely to be recommending having a delayed reconstruction because the long-term outcome is going to be much better. If we know at the start of treatment that a patient is going to be recommended chemotherapy, sometimes we suggest having that first, because a full course of chemotherapy can take several months. And that actually gives us some time where you can think about your choices, what type of reconstruction, whether it's something that you want, and also make plans. And if we're involving plastic surgeons, there are some logistic things that we can do. We've also talked about genetic testing, and sometimes that gives us options for choosing that, as that may affect the decision-making around surgery. Meredith Simcock is going to talk much more about the details of it, but that's my perspective as a cancer treating surgeon on reconstructions. Who does the operations? Breast cancer surgeons are trained as general surgeons. So we treat a number of cancers with that, but most in New Zealand would have had further subspecialist interest and training in it. There's various skills about who does which reconstructions or therapeutic mammoplasty. And some people do their own reconstructions, particularly implant-based, and some oncoplastic techniques. Certainly for myself, if I'm doing a flap or using tissue transfer from another part of the body, I definitely do that in conjunction with a plastic surgeon. I think all women should be able to have access to all options. So sometimes that'll involve just even a consultation so that you know that you've explored all the possible options. It's easy for me to say here, sat in Auckland, and obviously geography and in the rural or more remote areas, it's harder to get that. But I think it's a good aspiration and a certain starting point for how we should be approaching this.
Great. Thank you so much, Mike. That was excellent. I see there are a couple of questions popping up in the chat box. So if you do have something you'd like to ask, do pop into that chat box and add your own questions there. Now we're going to hear from Meredith Simcock. She's a plastic and reconstructive surgeon at Middlemore Hospital and also in private practice. Meredith, what does a plastic surgeon do? What do you do for your patients?
Right. Well, in fact, I think Mike's just given a really good summary and a good lead of what oncology and what plastics is. And part of what we do is a plastic surgeon is a surgeon of the whole body, and our aim is to restore form and function. When we apply that specifically to the breast, what we ideally want is we want to create something symmetrical, something soft, something natural that moves with you and has sensation. That's our goal. Our goal is up here. We're not quite there yet. We haven't quite got the technologies, but we're working towards that. And in many cases, as you've heard, there's going to be a little bit of a compromise, but we're working towards that. We're not, unfortunately, at this point, able to recreate your breast. Whilst I would love to give everyone that needed one a brand new breast that's better and fancier than the ones they've got, we are creating something to resemble your breast and to reconfirm that idea of wholeness. Now, we have a very specific role and we work very closely with other team members, particularly our oncological and oncoplastic surgeons, to treat the patient as a whole. You're not just a breast carrying thing to us. We add the breast to your life and we hope to make that a part of your life. And we have many techniques that we can use with the patient in discussion. And there are many things to consider. And as Mike said, this is a great option, but it's not for everyone. Not everyone feels the need to have a breast reconstruction. Not everyone feels the need to have a breast reconstruction immediately. There are many things to consider. And in every decision, there will be a compromise. And people will decide where they are willing to compromise on. However, the thing that we can't compromise on is that almost always reconstruction occurs in the setting of breast cancer. And this is primarily mastectomies, are breast cancer treatments. And then we come in to reconstruct. So if your type of cancer or timing of cancer or diagnosis of cancer is going to be delayed or interfered with by reconstruction, then it may well be that the compromise is that you treat the cancer and you come back and have the reconstruction. As we've heard from Erica, though, with the genes, we have got a population of patients who are having these surgeries and reconstructions without a diagnosis of cancer, but with gene problems. And that gives us a little bit more leeway and a little bit more time. The treatment that you've had, either for your breast cancer or for other medical issues, either treatment that you've had or treatment that you are planning on having, may also affect the timing for your reconstruction or the type of reconstruction that you've had. And as Mike said, if you've had radiotherapy or are planning on having radiotherapy, that may alter the timing of your reconstruction. If you are having chemotherapy, it may be that that happens before your treatment and before your reconstruction. So all of these are very individual things to consider. Not all of us are completely healthy. A lot of us have other medical problems that we may bring with us to the table with our diagnosis. And again, that may affect your decision with regards to the type of reconstruction or the timing of the reconstruction. You also, as a patient, have to be prepared to have more surgery. Whilst, again, ideally, we would like to do one operation and bang, that's it, it's done at the same time of your mastectomy, you will often need more than one surgery for a reconstruction. Even when things are going well, you need to plan for 1 or 2 or 3 surgeries, and you may have to plan for more scars on your body than you had originally anticipated. It's a trade-off. And again, some people find scars on their body more reminiscent. It reminds them of their cancer, and they would therefore rather not have more scars. So we may consider one type of reconstruction over another. Length of surgery, length of recovery, families at home, all of these make decisions very individual to patients. What I would like to stress is that there's no wrong answer and there's no right answer for everybody. You take all of these things to consider into account and you make the decision that's right for you at that time. In 5 years, things may be different. In 10 years, things may be different. The outcome that you have after your first surgery may mean that you then choose a different path. But at that point, when you're dealing with all of these things, that's the right decision for you. So don't second guess yourself and wish if and or but. So now let's get down to the nitty-gritty a little bit. We have 3 main types of reconstruction that we discuss with patients. Not all options are available to all people for the reasons we discussed. There will always be a compromise somewhere, but almost always we can find something that works if you want to go down that route. Mike talked a little bit about the timing. Immediate is considered at the same time as the mastectomy, and a delayed is at a later date once all the treatments are finished. And that may be 6 months, a year, 5 years, 10 years, or when you're ready. We try and give you a choice, but not everybody has a choice depending on their treatment. Implant reconstruction. This is an implant. I hope you can all see it. They're kind of squishy. They're usually firmer than a normal breast, so hence the comment about them feeling a little firmer, especially when they're under the muscle. This can be done as a traditional more 2 or more stage, and then a direct implant, which still often includes 2 stages, and there are different reasons to choose for these. So an expander implant or expander reconstruction involves the placement of a temporary empty stretchy bag to go under the muscle, usually, and then it gets stretched up until you're at the size that you want, usually. And then a permanent implant is swapped in about 3 months later. We almost always will do this in terms of a delayed reconstruction because you don't have enough skin and we have to create the skin. We stretch it up just like a baby in your tummy stretches up the skin. The expander in your breast will stretch up the skin. If we're doing a unilateral reconstruction, so just one side, an expander will often give us the opportunity to match the size a little more carefully on the other side. If you've got a very big breast on one side or a very small breast on the other side, we may put an expander in so that you can play around with the volume, so that we can plan to do a reduction on the other side or an implant on the other side to balance you. And this gives you a lot more control, a lot more participation in the decision-making process of where you want to end up. So again, surgery on the other breast will almost always mean that you have an expander in. We've also started to do direct implant reconstructions a little bit more. These involve the surgeon having a discussion with you over whether you trust your surgeon enough to pick your breast size. Now, there is a bit of that. However, saying that, we can stretch the skin a tiny bit and we can shrink the skin a little bit. So effectively, you're going to be roughly where you were within half a cup or so. It works very well for immediates where you already have the skin, and it works very well for bilaterals because we're doing 2 the same. So we have a lot more predictability of outcome. Those are my indications for a direct implant reconstruction. I will stress it's not always a 1 stage. Often it's a 2 stage or a 3 stage, and this will include some additional surgeries that we can talk about a little bit later. Things to consider for implant considerations. They're shorter surgeries, they are shorter recoveries, 4 weeks compared with some. The scars are limited just to the breast and it doesn't burn any bridges. However, you have an implant, it's a foreign body. You will get a scar around that implant which may become tight and may need more surgery. Implants are man-made devices and they may rupture. If they rupture, we recommend more surgery. It doesn't change as you change. So if you put on weight or lose weight or get older, gosh, it happens to all of us, they will always stay the same. So you're going to have a 20-year-old breast on one side and a 40-year-old breast on the other. Never mind. We can do something about that. And it can cause some problems with radiotherapy. Some people seem to be sensitive to the implants and the silicone and can have some systemic symptoms with that. And ALCL is a very rare type of cancer that has been in the news a lot lately, and if we've got time we might address that a little bit more at the end, except to say that it's extremely rare. We don't at this point need to do anything rash with any of the implants that people may have in, and it is very much an educational thing at this point, but we'll talk about that if we've got time. Using your own tissue, this is a great option. We tend to use the abdomen if we possibly can. It's one big operation to get the tissue from your tummy up into your chest. We can do it at the same time as your mastectomy or delayed. You have to have enough tummy. So one of the problems is if you're too slim to have one breast or even too slim to have two, it doesn't become an option for you. But if it is available, it's soft, it's more mobile, and once it's done, it's done. You don't need any more surgery in the future. You're not going to get scarring around it. You're unlikely to get, it's not going to rupture. If you increase or decrease weight, it will increase or decrease weight. Gravity will act on it. So you have a much more natural, for want of a better word, result. However, if we do it joining up the blood vessels, you're looking at a 6 to 8 hour surgery. It's a 3-month recovery, realistically. And as I said, we can be limited to the volume available. Sometimes, however, all the best will in the world, we do all the work and the blood vessels don't flow, and this flap can end up in the rubbish bin, which is devastating. If that happens, we have other techniques that we can use, but it is still something that needs to be considered. And because we're operating on the tummy, technically you can have some weakness in the tummy. However, as our techniques have advanced, this has become less of an issue. However, for people who don't have a lot of tummy, we do still have options. And this can be to combine the back muscle and fat with an implant. We get the softness and the blood supply of the back muscle, which means we can make up for the radiotherapy, and we get the volume of an implant, which means we can make up for the lack of volume that you have. The scar is on your back, which many people like because it doesn't remind them every day. Their partner sees it, who cares, but they don't, so that's great. Again, there are some cons with this. It's still a long operation. There is still a 6 to 8 week recovery. It does take away a muscle that is well compensated for, but if you're a rock climber or a kayaker or a cross-country skier or otherwise very active with your upper body, you may find that this causes some ongoing weakness. And you still have an implant, so you often will have the complications that go with an implant. Sometimes we can sneak away without an implant, but almost always this would be done with an implant. Now, I like to call these titivations, which is perhaps a little cheaty, but there is always going to be another operation. And this will be the final results, the cherry on top, the nipple reconstruction for people who haven't been able to keep their nipples, which we can do from local tissue or from sharing the nipple from the other side and tattooing. It can be fat grafting, which is taking fat from elsewhere on the body, if you have any, which is washed and injected around the implants to soften them or reshape them into contour problems or ripples, to increase volume. If, for example, you've had your tummy, you haven't quite got enough. And also operations on the other breast, which can be making it bigger, making it smaller, making it more youthful. All of these are available, and in my mind, a reconstruction is not completed until all of this is done. And this may take time. All of this process may take a year or 18 months or even 2 years. It's not something to be rushed into. And again, whilst we would like to be able to offer it straight away, one shot, you're done, you have to be prepared that this is a process. And to give you the best result with the most reliable long-term outcome, you have to be prepared to give it some time. But 1 year in your lifetime to give a great result is not so bad. Just a little bit at the very end, and I think we've really covered this, it's important to have your questions answered. If you have questions, write them down, bring in a list, go through them with the surgeon. If you don't understand what they're saying, if you don't understand the language that they're using, Ask for clarification. Ask for examples. Look at photos. You might want to take notes. You might want to bring a partner or a friend, because 4 years is better than 2. 6 years is better again. And often it's hard for us to remember a whole lot of information. And my consults last an hour or more, and it's hard to concentrate that long. So it's good to have 2 people. But I think we're going to place a list of some questions that you can ask on the website as well. And if you have more questions, you can always ask them later. We're always around.
Right.
Yeah.
Thanks. Do you mind just firing that? Okay, thank you so much, all 4 of you. That's been extremely informative, and from the number of questions we're getting through, people are really appreciating hearing on this subject. As Meredith said, we will have a checklist of questions to ask the surgeon on our website. We'll send you through a link to that. So now we're going to switch over to some of your questions. You can keep sending them through, but we'll just crack on with those. And one of the first ones is both these ladies talked about having under the muscle or over the muscle, and so what's the difference and why, which is more common and why?
Okay, I'll take that one. I'll do that one, yep. So traditionally, implants have gone under the muscle because when a woman has a mastectomy, it's not a cosmetic operation. We're taking the breast away, and often there's not a lot of padding left under the skin. And so if we put an implant directly under the skin, then you can often see ripples or see the edge of the implant. So the idea is that by placing it under the pectoralis muscle, which is about 1 centimetre thick in most women, you provide extra padding and extra coverage and extra support for the implant. In the last 8 to 10 years, fat grafting has become much more popular in breast reconstruction, which is, like I said, sucking fat from one area and injecting it under the skin to thicken the fat in that area, which can be used to disguise ripples or implant edges, for example. So in some groups of people who have enough donor site or thick enough mastectomy flaps, we're starting to see the option to use the implant over the top of the muscle. And in very specific patients, this can be a very useful technique. However, because it has only been going or been more popular for a short time, we don't have a lot of long-term follow-up. So implants under the muscle have been going 15, 20, 30 years. Implants under the skin for reconstruction have really only been popularised in the last 5 to 8 years. There was a period 12, 15 years ago when it was in vogue, and then it fell out of vogue again because it was difficult to disguise the rippling. There was an increased risk of capsular contracture, and people were finding that the implant's appearance didn't last as long. So it went back under the muscle. Now we've got more techniques. We've got a few more adjuncts that we can use in surgery. So we're going back over the muscle in a certain number of patients. Now that may be because they've had complications. That may be because they've got lovely skin and soft tissue. It might be because they're very, very active and they don't want to lose a muscle, and they want to do everything they can to keep the muscle. So much like all our other reconstructive options, we like to individualise. So all of these things are worth discussing and thinking about and finding out whether it is right for you. And it might be or it might not be, but it's worth exploring that with your surgeon, because every conversation that you have with your surgeon should ultimately come down to working out what's right for you as an individual to give you the best long-lasting result.
Right, right. Now a question about tissue expanders. Would you recommend tissue expanders to a woman who had a mastectomy 6 years ago and has one larger breast and is a bit overweight? Generally.
If that person wants an implant reconstruction, she would have to have expanders as the first stage, because you have no skin to match. Now, it might be that you want to have a reduction on the other side, so we kind of meet somewhere in the middle, stretch the skin on the mastectomy side out and decrease the breast size on the other side. If you've had radiotherapy, that may not be an option, in which case you'd be looking at bringing in soft tissue from somewhere. And if we were to use your back, you would probably still have an expander and a 2-stage reconstruction. If we were to use your tummy, then you can probably get away with a 1-stage reconstruction without a tissue expander. But if you're looking at an implant-based reconstruction and you had your mastectomy 6 years ago, you would need to have an expander.
Right. And Mike, with breast conserving surgery, do people ever have to come back for a second go at that, like they do with a mastectomy?
We always warn people when you're doing the surgery that what you're trying to do is remove the abnormal area and get a rim of normal tissue all the way around. And we only know that's been achieved definitively when the pathologist has looked at it. So not on the day of surgery, but a week or two later when you get the final results back. When we send the specimens to the laboratory, we always mark them as which way's up and down and left and right. And if it's a little bit close or involved on one side, then we do recommend an operation for that. If you look worldwide, the incidences of that are somewhere between about 1 in 6 and 1 in 8 cases, needing just a little bit more taken out. And that will be at the time of the initial diagnosis. Most people who have, but if it's all out, then it can be done, and we recommend radiotherapy. Most people who have a partial mastectomy and radiotherapy have a very low recurrence rate. They're kept under surveillance, but if in the small percentage of people who do get another cancer in that breast, at that point we'd be recommending a mastectomy.
Right. Okay, thanks. What are the risks and procedure for a lat dorsi flap reconstruction with an implant?
Okay, so a lat dorsi is the procedure where you bring the muscle and the skin around from the back. There are the risks are similar with or without an implant. So the risks in the short term are immediately after the surgery of having a bleed. We make cuts in the body, we make cuts in the skin and the muscle on the front and the back, and everywhere you get a cut, you get a risk of some bleeding. We keep an eye on you in hospital. We, at surgery, cauterize all the blood vessels, but sometimes even then you can get a little bleed under the skin or under the muscle, and we would take you back to the operating theatre, wash that out, and close everything up, and it shouldn't interfere with things in the long run. There's a small risk of infection. If you've got an infection just in the skin, usually antibiotics by mouth are all that is required. If you've got an infection that is not responding to oral antibiotics, you might need intravenous antibiotics in hospital. And one of the things that we get very concerned about if you have an implant is the infection going deep through the skin into the implant. If you get an infection around an implant, it is a disaster because we have to take that implant out. If you've had a latissimus dorsi, however, you can leave the muscle flap there and the skin flap. We would just take the implant out. So you would be a little flatter, but you'll still have some volume. And then we would come back 6 months later and put the expander back in and just carry on as if that hadn't happened. There is a risk of damage to the blood vessel. When we bring this tissue round, we keep its blood vessel attached in the armpit. If you've had previous surgery or radiotherapy, that blood vessel can be a little fragile, and whilst we wear magnifying glasses and look after it, there is a possibility of damage, and that can cause the flap on the front either to not work at all or to have some problems with its blood supply and maybe end up being a little smaller. Now that's pretty rare because it's a pretty reliable blood vessel. You will get scars. Most people scar very nicely, but some people make very lumpy scars. Again, as I said, the scar will be on your back, so you may well not see it, but you will have some scars on your chest. They usually heal nicely. If they do get very lumpy, we can treat them with steroid injections or trying to cut them out if it was related to something such as infection. You do need a second stage, which is once the expander's at the right size, you will need to have that swapped out for permanent implant, and you do run those risks again of infection or bleeding at that time. There is a risk of asymmetry. You do have a reconstruction with an implant that will feel firmer and won't be as mobile as a native breast. But again, in clothes, you should look very symmetrical, and even without clothes, you should look symmetrical, although it may feel slightly different. You may need more surgery on the other side to lift or reduce or shape that breast to match, which can cause some complications on that side. There will be some muscle weakness in the shoulder for a period of time. Most women over 6 to 12 months will build up the other muscles in the shoulder such that that's not an issue unless you are a very active woman in the upper body. Like I said, kayaking, cross-country skiing, rock climbing tend to be the main things in the long term to be concerned about. And I guess the one other thing which some people don't mention is twitching or animation. So we cut the nerve to the muscle, because otherwise your party trick is when you pull your arm in, your breast moves, because that muscle is still innervated by the nerve that controls your arm. So we try and cut that in surgery to prevent that happening, because otherwise you have a bit of a mobile breast. And sometimes we come back and do that later if we weren't able to do it the first time, or if it regrows. But again, that's pretty rare.
Right. Okay, so on the subject of implants, you talked about a situation where you might replace them. What is the life of an implant generally?
Okay. The manufacturers are saying really anything up to about 20 years. They don't have a best before date, so it's not inevitable that they need to be replaced. But over time, sometimes it's the implant actually gets some wear. Sometimes you may have had a bang or a knock, and eventually an older implant might rupture. The other thing that happens is just the way the body reacts to it. It's normal to produce some tissue around it, which is known as the capsule. It's a sort of white fibrous layer, if you ever look at it. And over time, that can contract. And rather than having a sort of flatter, narrower one, it will try and make the implant more spherical, so it'll actually get a bit tighter and rounder and sit more prominently. Implants only need to be replaced if they are showing signs of wearing out or change in any way. We do also recommend, we mentioned some of the other complications, if people notice a change in their implants or it swells up, to go and get it checked to make sure it's okay. And that really comes down to the condition we mentioned called ALCL. But yeah, somewhere between 15 and 20 years would be an average lifetime, but there are plenty that go on longer. You don't need to have them changed preemptively.
Yeah, I'd agree with that. And you also don't need to check them preemptively. It's not like they hit 5 years and you need to have a scan every year just in case. If they haven't changed, you don't need to do anything. You can just accept that they're doing what they're meant to do. And if they're sitting there happy and soft and roughly where they were, then just enjoy them.
Good to know. Now, here's someone who says, I've had a mastectomy on my left side only. Can you talk about what women do in relation to prophylactic removal of the other breast and then reconstruction of both, or just reconstruction on one side, or what are the reasons for?
In terms of having the other breast removed, there are some cancer reasons why people may do it. We've heard from some people who are gene carriers, so actually that's done as a risk-reducing procedure. There are certain subtypes of breast cancer, typically a lobular breast cancer, which has a higher rate of recurrence in the other breast. So that may be a reason people opt to have bilateral surgery. And there are some families where there's a very strong family history, and you can assess that as being potentially high risk of developing breast cancer in a lifetime, even if a genetic mutation hasn't been found. And those are people who might want to consider some sort of risk-reducing surgery on the other side. For the vast majority of people, in fact, who've had a unilateral or a one-sided mastectomy, they will not develop something on the other side. So to sort of widely offer that is actually over-treating large numbers of people. Many people will describe to me being so much more aware of their chest wall on the side that's had a mastectomy, that it's more sensitive and they're more aware of the muscle and it's a bit more tender. So having surgery on the other side can actually cause problems there, and a few people do develop pain problems as well. One reason that doesn't fall into those boxes, as I said, and perhaps a relative reason for considering it, is actually symmetry. And for somebody who's quite large breast, who's had one side with a mastectomy, they do feel very asymmetrical. There are some people who will offer reductions too, and occasionally for a mastectomy, but certainly our experience is that having a bilateral mastectomy does have a big impact on one's body image, and much more than just having one removed. So it's not a standard recommendation. As I said, after a cancer operation, you're under regular mammogram screening. If you've had any adjuvant treatments, be it tamoxifen or other hormonal treatments or chemotherapy, that's actually going to reduce your risk of developing something else. And the vast majority of people actually inevitably don't need it.
Right.
But do talk to your own specialist about your own individual situation.
I had a question for Vivian and Erica, which they've said they're happy to answer, which is about, could you talk about what sensation, if any, you experience in your nipples having had this experience?
Well, there is definitely a change. Because of everything that's being done, it does change the sensation. I'm not sure if it was because of my initial surgery, but my first nipple sensations was just chronic pain to the point that I wanted to actually get them taken off. But having done my second surgery, I actually am getting a lot of feeling back into them. I can actually, lots of details, it feels pleasurable now rather than intense pain. So it worked out really good for me.
For me, it's still coming back. So initially there was absolutely no feeling whatsoever. It's a little game me and my partner play where I close my eyes and I see, like, you know, at what point can I feel it again? And so it's definitely coming back, but I would probably still call it like a pinching pain almost. It's not pleasurable for me yet. It's kind of more nervy pain that I'm feeling. But I have hope. That's given me hope that maybe we're still you know, going to get better. So.
Yeah. And would you guys say that does improve over time, or?
I would counsel people to go into it expecting them to be numb and not have it. And if you have then it's a bonus.
Yeah.
Okay.
Yeah, that's what I say too.
Oh,
yeah.
Yeah.
So you guys have been really lucky, and that's really good. And a lot of it will depend on the size of the breast and how you tolerated it. But in general, we're cutting a lot of those nerves, and if you get anything, it's great, but don't expect it.
Right. Great. Thank you. That's really helpful. And I hear someone who said, I've had a tummy flap reconstruction and have stomach cramps when I bend over and feel pressure on my rib cage, muscle spasm if I wear a bra. They sound like things that should be looked at.
I would suggest that you discuss that with the reconstructive surgeon. Certainly there are different ways to use the tummy, and some ways involve using some mesh in the tummy, which can feel tight. Whichever way we do it, we do put stitches on the inside, and sometimes that can make people feel a little tight on the inside. And if the muscle is coming up over the rib cage to create the breast, I guess theoretically wearing a bra can put some pressure on that muscle and can cause some cramping. If you've had the reconstruction a long time ago, I would expect that muscle to have shrunk away, and it may be residual nerve pain, and it may be that something that the surgeon can suggest, either removing the muscle or elevating it. It may not be anything that can be done. You may have a small hernia. There are lots of different causes for some tummy pains, and it's worth getting them checked out, but discuss it with your original surgeon and get them to examine you and find out.
Great, thank you. Now here's someone who says, I gave up on implants when I needed an MRI and had a double mastectomy. I continue to be plagued by seromas and now have a whole 7 months after my second operation. How common are seromas and why do they occur? Do you want to just tell us what a seroma is first?
Well, so a seroma is a term for a collection of fluid in the body. The body doesn't like having empty spaces, so it will fill it with fluid. And if essentially that fluid is plasma, it looks pretty identical to the stuff that you get on your knee if you graze your knee, that sort of yellow fluid. It is not dangerous, and it can be anywhere from inconvenient to downright uncomfortable and painful. Most of them can be aspirated. That's basically using a needle and syringe and withdrawing it, and sometimes that needs to be done repeatedly, and unfortunately a small number of people will develop chronic ones or recurrent ones that do need recurrent treatments. I think so a seroma at all, if you look for it, is quite common in anywhere where there's space. At any given time, the body's secreting fluid into it and absorbing some, and for most people at some point there's more absorption than secretion. It will do dry up. This one sounds like a more troublesome one that needs a bit of specialist management. And if those simple things of aspiration and time don't do it, then there are a few other tricks you've got. And sometimes it actually does take another operation to wash the whole thing out and try and get the thing closed.
So should she be going back to her breast surgeon or plastic surgeon for that?
Yeah.
Good, okay. And she worries that this will produce a worse scar as a result of having these seromas inside, is that?
Not particularly. I think most women, if perhaps, for example, had a mastectomy at any point, they would have had a drain when they went home, and that's really to collect the same fluid that forms a seroma. So occasionally we get people, if they're long-standing, that it's done some pressure, perhaps stretched the skin, but hopefully not the long term.
Right. Now here's someone who's saying that she's been recently diagnosed with breast cancer, will be having a full left mastectomy, has confirmed cancer in her lymph nodes, so we're having those removed. If the pathology shows the cancer's gone further than the lymph nodes, can she still have reconstruction, and what are the options? Yeah.
I don't want to preempt what your own specialists have said, but you could potentially ask them, what their thoughts of the likelihood of needing chemotherapy as well, and likelihood of needing radiotherapy. And for many people who've got some lymph node involvement, if you know that at the start, then you're already thinking that chemotherapy and radiotherapy are going to be part of your treatment. So that may affect decisions around type of reconstruction and timing of reconstruction. There are people who have disease that has gone elsewhere, although even if lymph nodes are involved at the start, it's a small number of people who, when they present, have any spread in other places. Spread elsewhere does not preclude having a reconstruction, but it depends on where that spread is and how it behaves and how you respond to treatment. So if we know, for example, people do have spread beyond the lymph nodes to other organs, we may not recommend, we're much less likely to be discussing an immediate reconstruction, and may suggest saying, well, look, there are other important cancer treatments, and that would likely involve chemotherapy and radiotherapy, and actually reducing the amount of the complexity of surgery now will get you onto those treatments much quicker, and then see how the body responds, and then think about it after those treatments have been done. And it's a little bit of those saying, well, what are the things that I want to have and are important for me, and what are the choices?
Mm-hmm.
Yeah, I don't want to get into too much detail, not knowing all of your details, but that would be my sort of overview. Yeah,
and I think I'd like to echo that this is a cancer treatment first and then a reconstruction second for most women. However, for some women who don't have that choice because of a late diagnosis, having two breasts is very, very important to them, and it's certainly worth having a discussion with your oncologist and your general surgeon and your plastic surgeon, not necessarily in that order, about what are my options for further treatment from a cancer point of view, and then what are my options for reconstruction, because it may be that we can offer a one-stage, something shorter and quicker to give you something which you may find better than nothing. By you, I mean not you who asked the question perhaps, but everyone out there who may be considering this, because sometimes it's very important that you look and feel like a woman for as long as you possibly can. And so it's not a no, but it's you need to be very aware of how it's going to impact on the rest of your treatment and for timings of those decisions. And I think, again, if you've discussed it with everyone and you're making a fully informed choice and decision about and the implications that will have on your recovery, then we want to work with you to give you the best outcome that we can.
Great. Now, we've had a few questions about costs and public availability of these procedures. Are they all available for free and everywhere? If I'm in Dunedin, can I have plastic surgery?
So plastic surgery is based from plastic surgeons, is in Auckland, Waikato, Hutt, Christchurch, and a slightly smaller unit in Dunedin. There are also oncoplastic general surgeons in some of the smaller centres, particularly Whangarei. There's also Tauranga, Invercargill, and so other places around the country. Plastic surgeons will be the only ones who use free flap tissue from your tummy, which is the muscle preserving, slightly more fiddly, technique dependent use of your tummy. There are some oncoplastic surgeons who do use the tummy in a slightly different way. Some of the general surgeons will use your back muscle Many will just do implants. So again, wherever you are, it's worth discussing. All of the techniques that we provide for reconstruction are available in public and private in the main centres. They don't cost anything. Prophylactic surgery, if you don't have an indication that Mike spoke about earlier, will not be covered in public in Auckland, and probably not in other centres either at this moment in time, because it's not considered, it's not cancer surgery, so it's considered elective. So it becomes a little bit of a something that needs individual discussion, is perhaps the best way to put it.
And the indications I mentioned actually aren't covered by many insurance policies either.
Yeah, and so,
but certainly none of the techniques we talked about tonight are not available in public.
yeah, so all the techniques we discussed are, and if you are in a smaller centre, all of you will be hub and spoke to a main centre that has plastic surgery. So if you feel, certainly in a delayed fashion, it may not be available in an immediate fashion, but if you feel very strongly that you want to talk to a plastic surgeon about the use of some of these techniques and it's not available in your area, ask who your plastic surgical regional hub is, and you can get referred there and have it discussed there, and it should be available to you as much as it is to someone who lives down the road. So we're working on spreading the word and spreading the techniques through however we can, but you have the right to ask for a referral to your local plastic surgical unit wherever you are in the country.
Right. Now, we're at 8 o'clock, but we do have a lot more questions, so we will carry on for another 10 minutes, if that's okay. But because there are quite a few questions, we'll try and whip through them fairly quickly. Here's an interesting question. If a larger woman has had a unilateral mastectomy, so it's on one side, is it possible to have a reduction in the remaining breast and use that breast tissue for the reconstruction on the other side?
No.
Okay.
No, it's possible to have a reduction on the other side, but what we don't want to do in someone who's had breast cancer is to then move breast tissue potentially to the other side, which has had cancer in it, because it just confuses things. And also the technique of blood supply, the way the blood supply works to the breast, it has been done, but it's not a routine technique. We have much better, more reliable techniques that will give you a better result than doing that.
Okay. Is there a risk with lymphedema after reconstruction?
I guess there's a risk after breast surgery. Reconstruction doesn't add to that. So if you want to talk about the risk after breast surgery.
Yeah, I think most of the risk of lymphedema comes down to what is being done to the axilla and the lymph nodes. And when I talked much more about the breast component of it, and not, so the risk after sentinel node biopsy is minimal. The risk if you're in a position where you do need an axillary dissection or an axillary clearance, as it's sometimes called, there is a risk of lymphedema, and that's irrespective of the reconstruction.
Right.
But actually having an implant or a tummy flap or anything else isn't going to put your risk up. It's more to do with the cancer bit of the operation, if you like.
Right. How does a tattooed nipple look and feel?
I guess it depends a bit on the tattoo artist. It doesn't feel, it feels like normal skin. So the most common way to make the nipple is to use origami of the skin that's already there, which may or may not have a little bit of sensation. It certainly doesn't have any erogenous feeling like a natural nipple. It is a nubbin that we tattoo the colour on, and in some units can do some advanced 3D tattooing. We tend to use vegetable dyes and plant-based dyes, so they're not quite as durable as your high street tattoo, which is by design. We don't want to put anything foreign or unnatural that we can help in the breast skin. So they don't tend to last as long as something that was done on the main street. But depending on the experience of the tattoo artist, we can get very realistic colour matches, and we match to what's there. If you are a bilateral and you're having bilateral nipple reconstructions, you can choose within reason what colour it is. So you can get some pictures and say, I want cherry pink or dark brown or whatever. Navy blue, not so much, but nipple colours.
Right.
Yeah. And to be honest, if you're feeling flamboyant, you don't have to just have a circle, you can go and have something crazy done. But that's, again, we recommend going off to the local tattoo artist, and there's some beautiful work around.
Right.
Yeah.
Great. I've had chemo and radiation. Am I still suitable for reconstruction?
Yes, but that's a conversation to have with the specialist of what they would recommend. So, I mean, to simplify again, a reconstruction is needing some skin for the breast and some tissue to create the breast mound. And if you've had radiotherapy, in some people the skin just isn't as stretchy, so you do have to provide some skin from somewhere else. But having had those treatments does not preclude you from having it, but it may limit your options.
Can you recommend a good website or source of reconstructed breast images for people to look at?
That's really difficult because yes, there's a lot out there. No, probably not off the top of my head. University of Toronto website has some reasonable images. You guys got some, you don't have any photographs, do you? I think the problem is with putting photographs on the web, and certainly I don't put patient photographs on the web, is confidentiality. So often if you look at the big names of plastic surgery, Bill Adams, there's probably something on his personal website. University of California's probably got some on their website because they're bigger places, so they don't have such a small catchment, so they can put photos up of other patients. But no, I don't have a single source.
Did you ladies look anywhere at pictures online?
Yes, I was an avid Googler for many months before going in. And for me, actually, the most helpful place I went to, because I was BRCA, then I am on a Facebook page called BRCA Sisterhood, and so it's a worldwide page. There's thousands and thousands of people on it, and everyone's really open with sharing their stories and their journeys, including like all stages of reconstruction. They have their own blogs and they share their blogs on the Facebook page, so it's all them, them putting forward their stories just to share. So I found kind of those avenues much easier to get information than just your standard Googling on websites. That was a little bit tricky.
Yeah, mine was a little bit different. I was more focused on just getting through the cancer process and going through chemo, and in the end it didn't really matter. I just kind of wanted to be able to live for my family. The only images I did get was actually sent from Erica. She would send them to me and I would look at them, but in the end I just trusted that it was going to turn out okay in the end.
And in New Zealand, can you get a double reconstruction using a tummy flap?
If you have enough tummy, yep. That's the limitation. And if you've had the mastectomies, either both of them already done or the indications so that you're eligible to have them done either under insurance or self-pay in private or in public. Yep, if you need it, that's what you get.
Right. Let's see what else. I think we're nearly there. Are you ladies part of a BRCA support group in New Zealand?
Yes.
Yes.
What is that? The gift of knowledge? Or?
So I jumped on the website, helpful website, but the BRCA, I think it's just called BRCA New Zealand, isn't it?
Yeah. It's a Facebook group. It's really wonderful because there are a lot of questions you want to ask, and having other people that have already gone through the experience means that you get a more personal individual response rather than a general, which is quite good just to see the pros and cons.
Yeah, definitely. And because the BRCA Sisterhood page was an international page, so you don't get a lot of like district health board question and answers, where the BRCA New Zealand page you can kind of get a bit more local information. So that was really helpful.
True. And we would also say the Gift of Knowledge website, if you haven't seen that before, which is also for people with BRCA and other genetic mutations. Okay, we've talked about chemo and radiation. How soon after those can you have reconstruction?
I'd be saying for radiotherapy, I'd be recommending people wait a year if they can before having surgery. Occasionally we get our arm twisted to do a little bit sooner, but at least a year. Chemotherapy, really just time for the body to recover. So depending on how the chemotherapy journey has gone, surgery can be performed maybe 4 to 6 weeks after chemotherapy is finished.
Yeah, that's if it's needed for the cancer. If you've already had the mastectomy and you're having chemotherapy and you're wanting to get through, we would push you to leave a little bit longer, sort of 6 to 8 weeks minimum, because chemotherapy affects the whole body, so all the blood vessels are a little bit fragile, all the tissues are a little bit fragile, your immune system's not quite as functional as it should be, so the risk of infection is a little higher. So you're just, again, a week or two in the grand scheme of things to make sure that you get the best possible outcome with the fewest complications. Much as everyone wants to get on and do it, it really does or can make a difference to the outcome. And the same with radiotherapy. We call that the gift that keeps on giving. And it does take a year for everything to settle down because everything is still fragile and friable and tight, and it's always going to be that. But at a year, everything seems to have plateaued and be stable.
Okay, so we are going to wrap up now. Thank you very much, everybody, for participating tonight, and thank you especially to all four of you. That's been really valuable, clearly, to everybody out there. You'll be sent a link to the webinar, which will be on our website tomorrow. And as you leave, I've gone too far there. Do I need to go there? That's okay. As you leave the webinar, you will get a short survey popping up to fill in, or a link to a survey, and if you could fill that in, it won't take very long. We would be very, very grateful for that. If you have any questions about breast cancer or breast health, please call our nurses on 0800 BC Nurse during office hours tomorrow. And that's it from us. We'll be in touch about the next webinar soon. Thank you very much. Good night.
Good night.
Thank you very much. Good night.